Well, we're learning new things constantly and faster and faster. And, you know, part of us says, you know, we don't want to change too quickly because we know what works and we don't want to harm people. But we end up having to change when something becomes really obvious. Two things that made me think of the story about your stereotactic training when the radiologists were like, oh God, you know, we don't need to do that. When you went to a Steve Parker course around that time, he started saying, and now the radiologist will be in charge of breast surgery. The radiologist will now be in charge of making the diagnosis, making sure it's right. Pretty soon we'll be using, you know, minimally invasive procedures to do the cancer operation. And so they only let a few surgeons in there because when the surgeons heard that, they went back and told other surgeons, hey, we better learn how to do this. You know, that's when Ricky Fine started doing courses, and Phil Israel started doing courses in Marietta. And that kind of pushed the start of the ASBS.
I was number 67 on stereo certification at the ASBS.
Is that right?
I still have my original certificate because I was like, I didn't want to do anything without doing the highest level of proof, because I had to fight some places where I've been to have stereotactic procedure.
But the thing privileges. That protected us was the radiologists, bless them, because they play an important role, but they did not want to be the doctor.
So that is where we are right now, right? Because when I'm listening to all this discussion, what I'm thinking about is where we're going.
Right.
And we've seen this across the I-SPY 2 trial. We've brought in two lesions that are, two drugs that are intralesional injections.
Right.
And I feel very strongly that surgery needs to own that space.
Yeah.
Right? I don't sense as much that the medical oncologists actually want to inject drugs. They don't actually inject chemotherapy, right? It's given in the chemotherapy suite by the nurses. But we have really pushed strongly that the surgeons should own the intralesional injections.
Right.
And there's some of the sites where the radiologists want to do those injections, but I keep trying to keep radiology on the diagnostic aspect and us on the therapeutic aspect. And I think when we think about that over the next 5 to 10 years, and I don't know whether intralesional therapy will take off or not, but I mean definitely cryoablation, you know, heat ablation, all that stuff. We need to own all of that.
Is this part of the trial that Brian Zernicki's part of? The intralesional? He's down at Moffitt.
It's part of I-SPY 2.
Yeah, I'm pretty sure it's the...
Moffitt does have I-SPY 2 open.
Yeah, that's because I saw some of his data at BC3, which blew me away.
But this is part of a little bit of a challenge we have with our colleagues, because we want surgeons to come along and not just stay in the, you know, place where they're going to end up just doing gallbladders at some point. Because you've seen the trial at MD Anderson, Henry Curer has, where if they have a complete clinical response, they are doing just a vacuum-assisted excision of the biopsy site, and they're not getting surgery, and they're going on to radiation. Well, I do stereotactic biopsies, just like you do, but most of our colleagues don't. And it's going to end up being the radiologist. And one of the problems they had in the beginning with that trial is the radiologist would take 6 cores, or maybe 8, and then they would be terrified, you know, because the bleeding is a problem.
And they would do a small gauge biopsy as opposed to an 8 gauge to actually get good tissue to be able to genomically test it.
So I think we ought to do that.
The trial that just reported out in Lancet had very clearly defined like number of biopsies and gauge. I mean, and then what was amazing is of each core biopsy that was taken, there was, if they didn't see disease on the first cut, was 12 slices. So it was basically, if you think about it, 12 slices, and I think it was like 9 different sites that were biopsied around the tumor bed. So you're looking at about 100 pathology slides in order to omit surgery on that patient. It was a pretty intensive interrogation of
We debated this, my friend Pat and I, at Miami a couple years ago.
We had the trial open, so I've had a couple of patients, one patient on it that was one
and
of
the
mine.
question that we had was not, will surgery eventually be unnecessary? The answer is of course. Absolutely. But is multiple cores at the current time on an awake patient less invasive than a sedated patient, small incision? And that's what we were debating.
Well, and I've got a lot of colleagues, I was talking to one today who was saying, gosh, you know, that stereotactic biopsy, but it must be horrifically painful. I would never have that done. I would much rather go get a very beautiful oncoplastic incision. And I have to tell them, it's not really painful if you do it right. If you put in, you know, local anesthetic, I give my patients a little sedation, some Valium, and it's nearly nothing. It's not nothing.
I remove all image evidence of fibroadenomas up to like 3 centimeters at least with ultrasound, because a lot of patients get a core biopsy. They get a phone call from the radiologist say it's a fibroadenoma, and they go, but I don't want to feel it. And that's a conversation you should have had before you even had the biopsy, because you know, if it looks like a fibroadenoma, even if it turned out to be a phyllodes tumor, if you're removing all image evidence, you're not doing anything to hurt the patient by doing that, you know? And the ability to do that under local anesthesia in the office with excellent cosmesis, it's an underdone procedure, which is why it just bugs the crap out of me that fellows are not finishing their fellowship with ultrasound certification. They're just not being, I don't know, do your fellows use the ultrasound every day in the office?
Our fellows have a pretty robust ultrasound experience because they actually go down and spend a month with Ricky Fine and the group down in
But
Tennessee.
see, but this is what you have to do, because all the fellows from Penn and Bryn Mawr used to have to come, you know, and from the University of Pittsburgh, because they'd go to radiology and they'd be able to watch. But with us, they were able to do the biopsies and do the stereos. And I just think it's something that the fact that we are de-escalating surgery, we talk about it every day. As we de-escalate surgery, why are we as the surgeons giving up that interventional piece? You know, I gave up doing most of my biopsies between during COVID and 2019 because I was seeing 10 or 12 new breast cancer patients a week, so I couldn't do the biopsies. And, you know, like, plus I had really good dedicated breast imagers that I actually trusted that when they told me that they got something, or I could look at the images myself and they would look at a post-biopsy mammogram and actually describe where the clip was so that I would know that it wasn't like a half a mile away and that I had to put a new marker in or something. So that piece of giving all of this up, like, I still believe we need to keep pushing for our breast surgical fellows to have that skill set.
They need imaging skills to guide what they're doing, because that's the whole future of surgery is image-guided surgery. The vacuum-assisted excision that you talked about for fibroadenomas, well, it's normal. It's really standard in the UK and in Europe because of limited resources. You know, we have a lot of reimbursement going on. We have more resources. Certainly the National Health Service is really strapped and they have to decide about every dollar. They're not taking those people to the operating room. They're doing vacuum-assisted excision. Even in the UK for atypical ductal hyperplasia.
I'm not even in contralateral prophylactic mastectomy either, and they may be onto something there.
Oh yeah, in fact, Mike Dixon has started advocating not even offering mastectomy as an option, because the data suggests that
goes
it's
way
bad.
back. I have been debating Dixon on this for 15 years. Eventually, I mean, to assume that every single patient who comes through the door values the breast equally is just not right.
It's a big assumption.
Right.
It's putting your value assessment on someone else's global healthcare picture. Not that I'm not the biggest proponent of breast conservation in the world, I am. But when Dixon says we don't even let them know it's an option, then I have a problem with that, you know. And
to your point, I mean, we talked today about this whole going flat model, where women are, if you don't mention going flat, and if they ask about it and you poo-poo it, you're a bad doctor. They say, go to another doctor. Your doctor is not informed. So you're right, they don't have the same preconceived notion about the breast.
We have a high rate of everything. We have a high rate of contralateral risk-reducing mastectomies. But I can tell you that practicing in New York, patients come in with knowledge, they've done their homework, you're their third opinion, and they drive the boat a lot. Mm-hmm. This is not us talking them into mastectomies. This is, I've done my homework, and this option, whatever it is, makes the most sense for me. And I think we've got to meet, these are patient-driven decisions, not doctor-driven decisions.
But we all have that same experience where the patient comes in, she says, Doc, I'm glad you're in here now. I want to have a mastectomy. I want my breast off as soon as possible. And sometimes my nurse practitioners have seen that patient first, and they come in, they tell me, she knows what she wants. This is going to be a quick visit. And I'll go in there and say, we're going to...
It is very quick if you just do what they want. It takes a lot longer if you try to counsel them.
When you try to educate them.
You have to have the relationship, because everybody initially will say mastectomy, and you've got to drag your feet and slow down and get to know the patient. It can't be a first visit,
I tell them we're going to do what you want in the end, but I need to give you some information. I want you to really have all the information in front of you, and there's no hurry here. The house is not on fire. We used to rush people to the operating room. We've learned that that's silly. Right. And so here are the reasons, and there is absolutely no advantage in terms of survival. So we go into all of that. at least half the time or more they change their mind.
Oh, yeah,
Thank
definitely.
God. You know.
Thank
That's
God.
that's what I teach when we do the fellows course. I tell them one of the first things out of your mouth when you sit down with a patient and their loved one should be, look them in the eye and say, no one has ever died of breast cancer in their breast. And then they kind of look at you, and it's like, you die when breast cancer spreads elsewhere. And if I could remove your breast and guarantee you that your cancer wasn't going to come back anyplace else, we wouldn't even be having a conversation, because that would be the standard of care. But we understand, because of Halsted and Urban and everybody that came before us that thought the bigger surgery created longevity and the ability to escape dying of breast cancer, we're never going to go back there. Yeah. And so at that point, it's about reframing this whole picture. And then, you know, we've talked about it a lot today. I am like one of the biggest survivorship advocates, probably.
I think you are the biggest
I might be.
survivorship advocate.
Because
You've really been a leader in that
the
area.
whole
No
the
kidding.
whole idea of how we do what we do is like, I'm a really good technical surgeon, but if that person is not happy at the end of their surgical process, I haven't done my job. And I've said it over and over again. If I had a device that cut out fear when I cut out cancer, I could be the best breast surgeon on the planet, because it's that fear that permeates, that comes back, that gives them the scanxiety, that gives them the inability to get on with their life. And that's where, at this point in my career, I'm really focusing a lot of my attention on that aspect, because it's the one thing that we really haven't made a lot of headway with. You know, we have survivorship care plans, but a care plan is a piece of paper that checks off a box with the NAPBC. But, you know, really going from surviving to thriving and putting cancer in the rearview mirror is something that none of us are taught in our fellowships. Nobody's taught learning about it in surgical residency. And it's something that, you know, I am doing the course at the ASBS this year. I'm very excited about that. They've asked me to head up that course, but I think it's going to become much more front of mind, because people are learning that, you know, regardless of whether you have a lumpectomy or mastectomy, it's what you do with the rest of your life that impacts everything else. Right. And when we figure out which patients, if we do breast conserving surgery on a patient who has high anxiety, who has scanxiety, who has just cannot get past the fact that she's living with the
time bombs.
If she sees her breasts as time bombs, and this is what, is it Carol from South Africa? She was talking about this, that if you don't query the patient and find out what their underlying belief is in their head, and you can't get past that, it doesn't matter what operation you do on them, it's never going to be enough.
Well, given the demographics, though, if you really look at it, the vast majority of breast cancer patients are cured. And there's a big group that you can look at and say, you know, your likelihood of cure is 95%. And so we address that stress aspect from the very beginning. And a lot of patients, I'm able to tell them, we have a little chart about, you know, levels of stress, and we talk about that and things to do for stress reduction. I tell them, you know, the biggest danger to you from this cancer is the stress. It's not the cancer. I think we're going to fix that. I expect that that's going to be fixed.
I
but
think starting
stress can
these
kill you.
visits with that, I couldn't agree with you more. Non-palpable subcentimeter luminal A breast cancer in America has a 98, 99% survival. Patients don't know that, and they don't think that way, and they don't hear anything I'm saying until you say, let me show you some data to put your mind at ease. This is really, really, really. They used to not let us say curable at Sloan. They would say, you can't say curable. I say it. This is a highly curable breast cancer.
Most patients are cured.
Most patients are cured.
And
The odds
what
are
you mean is
overwhelmingly
they're
in
going to
your
die of
favor.
something else.
That's
you know.
right. And then usually they hear the next 5 sentences that you say, because you've taken that roaring noise of anxiety off of their back. So
One of the things that I've done with my patients in consults, regardless of tumor subtype, you know, I do stage, grade. I like make them a kind of a rap sheet, and it has like the specifics, you know, the stage, the grade of the tumor, the type, and then I have local treatment, systemic treatment, like as my 2 columns. And I never do local treatment, which is my job, but I start with systemic treatment. And I have my list of, I call them opportunities for improvement, which is lifestyle modification. And I go down over all the things that, you know, that we should be talking to them about long-term, you know, survivorship. And so many patients have come back and said, you know, you started talking about lifestyle and exercise and nutrition and watching alcohol and blah, blah, blah. It's like, I kind of felt like you expected me to live.
You thought I was going to live.
You expected me to live. So it de-escalated their anxiety. And then we went back and talked about the local treatment. And that approach, you know, I've given that information to the fellows. I give them my rap sheet so they can go use it. But it's a different way of beginning to set that intention for that patient, that you're investing time in how they're going to work on their lifestyle, because 75% of our cancers are related to lifestyle, you know, opportunities that we have. And so that little piece is something that, you know, it's like a little gem that, you know, and a lot of patients come back and they're very proud to tell you what they've changed. And, you know, it's like during COVID, we all probably drank a little bit too much wine. I know I did, because of the, you know, you go home at night and it's like, okay, that glass of wine just tastes better. But when you look at the overall picture for our patients and we talk to them about, you know, probably shouldn't have more than one drink a day, maybe 5 days a week. And, you know, you look at the data on nutrition and sleep and stress, and enough is there. And that's, I mean, I'm speaking to the fellows on the 17th. They gave me a small topic for the fellows lecture. It's surveillance, survivorship, and lymphedema prevention. I'm like, well, those are all, that's like 3 hours worth of lectures.
I had one patient say to me, okay, but can I have 5 drinks on one day and just skip the other days? You know, does that work out?
What did you say, by the way? What was your answer to that?
I said, unfortunately, that's not how it works, you know.
A few years ago, we started, through one of our fellows who became an attending, what we called MUSIC, Maimonides Urogenital Sexual Health and Intimacy Clinic, to deal with all of the collateral sexual, psychosocial, sexual damage that things like aromatase inhibitors that we dismiss as Flintstone vitamins at times. And those clinics are booked 6 months. We can't keep up with the demand for that. And again, it goes to what you're saying about, it can't just be about the quantity of life, it has to be about the quality of life as well. And
So that raises the topic, of course, of nipple sensation, which is also something we spent some time talking about the last couple of days, but that's been another kind of advance in the practice. And I mean, I always try to bring up that topic of nipple sensation and the importance in kind of sex life and recovery after breast surgery. But we've been working with the nipple neurotization techniques with our plastic surgeons. So that's another area that I'm very interested in.
What's your sense of the success rate of that?
It is just too early to tell. So, I mean, we've been doing kind of the Sims-Weinstein filament tests on everything, but the nerve graft is about 7 centimeter nerve graft. And when you think that nerve runs through the breast and now you're wrapping it around your expander, and nerves regenerate about, a centimeter a month. So it's going to be 7 months. So the interesting thing was I operated on a colleague of mine who is a highly renowned researcher, has a lot of grants, not in the breast cancer arena. And she shows up on the morning of her surgery and she goes, I want this neurotization technique. And I'm just like, I don't know, you know, what the data is, we don't have it, all of this stuff. Anyway, we do the neurotization with the nerve graft. And the day after surgery, she's like, I have sensation. And I'm like, well, that's not from your nerve graft. I'm like, you are an intelligent physician, researcher. I'm like, I told you, if this nerve graft works, it's going to take 7 months.
Well, I don't know that the younger generation understands that. So our first skin-sparing mastectomies were a circle around the nipple, and all of the skin around was woody, absolutely. And yet when you leave the nipple, that sensation is dramatically better. There's something about the synapses in the subcutaneous nerves at the nipple that help you with that. Because the days when we removed the nipple in everybody, it was insensate and it did not come back. We see improvement, we think, over time now with nipple sparing. But this is the next major step.
Right.
That is in the category of things that I start out super skeptical about, you know, and we've seen so many things like that turned out to be real when we were skeptical in the beginning. Yeah. And I'm very skeptical about that, but a lot of my colleagues are doing it, and we're getting early reports of really good results with 2-point sensation, discrimination, and all of that.
That's really
but I have to say, I'm looking forward to that data, like so many things that we've seen. Yeah. I did want to mention, because we're a little bit older generation and a little bit younger generation, the contribution that different people make in different roles. I'm mainly in a private practice setting, but doing a lot of clinical research. But your role, Judy, has really, I can remember you and I talking at the ACOSOG meeting many years ago and talking about this question of what do you do with the axillary nodes in patients who have chemotherapy, who have a good response, who don't have a good response. And we had, I think, 2 or 3 years worth of discussions about this. You were the person who took it to the finish line. You're the person who got this study done, and I think we're now able to avoid lymphedema. We're really moving in that direction, and it's because of your leadership in that area. And that kind of is a segue into the reason we all came here today, because now we are really trying to target what lymph nodes we remove. We're trying to
You just
target
sealed the deal.
what tissue.
Her face is on my lymphedema, on my de-escalation of the axilla slide. So could I take a really good picture tonight? Yeah, thank you. Because when you think about that, you think about the stuff like, how cool is it that I get to sit here across the table with you, and you did the research, you did the work on sentinel node. I got to
Wait a minute.
No, he educated me. He did. He was one of the people doing the. But to think, I took a train to Memorial Sloan Kettering, did a 2-day course, learned what I needed to learn. I pretty much taught myself how to do it afterwards because I knew my way around the axilla, But it's just to like that. I didn't go have someone teach me how to do a nipple sparing mastectomy. Right. I knew how to do a mastectomy. I watch it. It's funny now because people will come up to me after I teach them and they're like, thank God you have your videos online. Like because I'm on a couple different sites doing nipple sparing mastectomies, and surgeons will come up to me and say, thank God that you did those procedures, because I learned so much from watching you do that. And you think, I didn't get to go look on the internet to look at sentinel node procedures back then. I didn't get to go look on the internet to watch someone do a nipple sparing mastectomy.
It's a subaerial duct excision plus a skin sparing mastectomy.
Right, but like when I do medical missions like to Haiti, I had to go do a circumcision. Luckily, I could Google circumcision and watch it, and it freaked my son out because he's like, Mom, don't you do these all the time? I'm like, no, I'm a breast cancer surgeon, but I got to do circs down here. I can do hernias, but I don't know when's the last time you did a circumcision. But that's a big operation in Haiti. So, but you can now anybody can go look at a lot of these procedures and watch them being done on the internet. And now I had people that chose me to be their surgeon because somebody that they knew someone, and then they sent them the site and they watched and they're like, I'm in Sedona, Arizona. Why did you fly here from Seattle? It's like, well, my friend's a surgeon and said, you have good hands to do this. And it's like, so times have changed. And, where are we going to go from here? I don't know. I think I'm hoping that we continue to de-escalate what we do, that we get more and more surgeons and physicians to honor the data-driven results on our genomics, on our outcomes, and that breast cancer becomes something that, once we can really, get great techniques for early detection. Some of the studies coming out of MIT with using the AI and the machine learning for, they're able to see these cancers 4 years before we're detecting them. There's some really interesting stuff happening in that.
And blood tests for breast cancer, and actual blood tests to determine if you're responding and how well you're responding, and do you need more intensive follow-up? All sorts of things are happening, especially in colorectal cancer. Breast cancer used to lead the way. We had the biology, we knew about estrogen receptors, but now we're getting eclipsed with biological information in colorectal cancer, with circulating tumor DNA, in lung cancer with a whole lot of comprehensive molecular analysis.
Yeah. I just hope that the future for breast surgeons is as bright as the past. Right, so in the early 90s, the HER2, then HER2/neu stuff showing how dangerous that gene was without an immunotherapy was done in a surgical lab. The founder effect mutation in BRCA2 was done partially in a surgical lab. Sentinel node, we have a lot to be proud of, I think, in our legacy. I just hope that the next generation continues to fight, whether it's intratumoral injections or to maintain primacy in this specialty, because I really think it's still a surgical domain.